I'm terrible at talking.
You would think I wouldn't be, but I am. I get up there in front of the podium and my my brain just goes
Oh,
into
that's mine. That's,
hyperlock.
yeah, totally.
I knew I was here for a reason, but can't remember what it was.
Okay, I'm sorry about my delay. Route 2029 was we're going at a crawl, turtle speed. All right. First up, 1081. Relevant insurance payments to ambulance providers. So I think I've done this bill before. uh, so I guess first of all, who's on this subcommittee? Let's make sure we have the. You had your nice little list yesterday. Do we have it? Yeah.
She's on.
Okay.
The challenge?
Okay. And Representative Gibbs, you're on.
I am.
Yeah.
Okay.
Okay. So the issue comes down to is that the insurance companies are paying the patient rather than the rather the ambulance companies, and the ambulance companies are saying that, well, insurance companies pay other providers that are not necessarily in their networks. Why are they picking on them? And the upshot being that the And I guess, you know, if we understand the role of managed care and the invention of managed care was that the whole point is that the insurance companies would have contracts with providers. And we dealt with the problem, obviously, when it came to anesthesiologists and pathologists and other ones when it comes to the hospital, but that the hospital was in the mix there. In this case, this is just an ambulance on its own. Obviously, ambulances are a very unique industry in the sense that they're 24/7, but at any, you know, but they're sitting around waiting to get a call. You know, they're not. It's not like they get guaranteed clients in business, and then I assume that's the reason why they don't sign contracts, because they don't get enough money for not doing any business. So I guess let's hear from the subcommittees and how you guys feel about this bill. You want to? So Vincent's on this one too? How did he get? Yeah. How did Vincent get on two of them? That doesn't make any sense.
I can
Okay.
sub for Vincent.
I know, but how does he get on? I thought he was on liquor yesterday, and then how did he get me into? Didn't I switch him around? Let me look on the wall.
Looks like he's on insurance. You guys all made the news yesterday. You guys all made the news yesterday. Yeah. Vietnam.
Yeah, I didn't see it.
Yeah, it's all.
Adam's sitting.
So Anita, you're already on it.
Oh, I am?
What's the correct list? We have two.
Okay.
How do I get on this?
So yes, Vincent is on it. He is. Barbara. Oh, so who's not on his post got switched with McHugh?
So this is
You're on this?
the one I showed you.
Okay.
Except
Right, because I made that switch between McHugh was gonna, he wanted to be on this one. Of course, he's not here.
Yeah, I think you're going to.
she did the same one.
Okay, so this is the same one?
Except Vincent's not.
Vincent. And who's on? All right.
All right, so I think. So we need another sub or no? We're good?
Well, I guess I'll have to replace McHugh because he's not here right now. I mean, if we're gonna end up, you know, being 4-4, then obviously we're not gonna want to go forward with this bill, but
With you and
I don't know how everybody feels about it. Yeah. Obviously, just for the record, the committee has killed this bill multiple years. And simply because this is contractual issue. It's about getting a contract. So, Representative
I
Spear.
thought that we,
So the question I have is kind of like related to that. If the ambulances get the money, does that imply that they cannot also bill the insured person because the money that they got from the insurance company didn't cover even half of what it actually cost to do it?
Right.
Is there a limitation there as a
In
result of
terms
that?
of them doing the balance billing.
Right.
Okay. Someone want to respond to that question? You would say, okay, yes. You can always balance bill, right? So that was the one difference about this bill, this piece of legislation, undifferent from what we did with those other professions, was that balance billing is still in here. That the only difference being is that they want the check to get mailed to them directly,
Right.
rather than going through the patient. And I guess I'll tell a little story on this one. So one of my employees, a deer attacked his truck, and the insurance company sent me the check. Well, the check is clearly way too low for what it's going to cost to repair it. and they said, well, you just hold on to that check and then give it to the whoever your auto body shop is, and then. But my deathly fear is if I cash that check, then I'm accepting that payment. And so it's kind of an awkward situation. So I would assume, and the same thing happens with these patients, that if they get that check in the mail, they would know not to cash it, and they would know to turn it over, because they certainly wouldn't want to be in a jeopardy situation. So Representative Gibbs.
Thank you. I've been in this situation several times,
Okay.
and the problem was never one that the insurance company didn't pay enough for the ambulance company to accept it. The problem was simply that they sent it to me,
Right.
and then I had to figure out where to send it. And there was one instance when the company changed ownership in between when they had taken me to the hospital and when I sent them the check. So I sent the check to the wrong place and they sent it back to me. It was an incredible complication. And for that reason, I strongly support this bill.
Okay.
Mr. Chairman, my understanding is that the people were getting the check and cashing it and keeping the money. And that's why the insurance companies wanted it to go directly to the ambulances. And for that reason, I would support this bill as well.
No, the insurance companies don't want it to go directly to the ambulance.
Right.
Wait, say that again?
But
Okay, so why don't you kind of have to come up and speak to the
The
microphone.
ambulances that want it to go directly to them, and the patients also.
And identify
Hello,
yourself.
for the record, my name is Michelle Heaton. I'm the Health Law and Policy Legal Counsel at the Insurance Department. And this issue has a very long and sordid past, as Representative Hunt alluded to. It's been a problem for many years, this issue of balance billing, where a out-of-network ambulance responds to emergency situation, provides the transport, and then the person's insurance gets billed. Because that ambulance provider is out of network, there is no contractual relationship between the insurer and the ambulance provider. The insurer pays what they would consider to be a reasonable rate for those services. And because there's no contractual relationship between the parties, they send it to the person they have the contract with, which is the patient. The reason there is this provision in law that says you can provide it directly to the provider or the patient is if it's in network, you're going to send it to the provider because you have a contract with them. If it's out of network, you send it to the patient because the patient is the one ultimately liable for these services that were out of network. And what's going to happen is the ambulance provider is going to bill the patient for the services they rendered. The patient is supposed to use that check they got from the insurance department to pay the provider. Now, this is just one aspect of the issue. Currently, ground ambulance is the only service that in emergency situations, you can still balance bill the patient. So if the provider doesn't feel like the insurance company is paying enough for their services, they can then bill the patient for the amount that the insurer did not cover. That is the bigger issue that still needs to be addressed here. This bill, the way it's written right now, is only making it so that the provider will receive payment directly from the insurer that they do not have a contractual relationship with. Over the summer and fall, the insurance department, recognizing that this is still a major issue for consumers and a major issue in the insurance industry, we convened a stakeholder group together to try to address some of these issues. And if you'll give me a second, I can give you a quick recap of what we talked about in that. So for this work group, we were specifically focused on the role of commercial health insurance when considering the overall funding of ambulance services. We wanted to address the problem of surprise billing, the balance billing to the patient, as well as the problem of establishing a more rational, stable, equitable funding mechanism for ambulance services and the role of commercial health insurers in that system. We also were looking at the problem of the inefficiencies in the current system and an opportunity to improve service delivery models. Everyone agreed that ambulance providers are vital to emergency response in communities and an integral part of the healthcare system. We were able to identify some common ground on a number of issues. There was agreement that ambulance providers need adequate funding to ensure they can provide necessary services when called upon. There's also agreement that the current emergency transport system is inefficient and that better delivery models ought to be available. Although there's very little support for the idea of continuing surprise ambulance billing, ambulance providers are generally loath to tackle that issue in isolation without also solving the overall problem of how best to fund emergency services. The overarching policy issue that prevents stakeholders from reaching any further consensus is whether the funding of these services, where the funding for these services should come from. Some argue that communities should decide what emergency services will be available in their community, and that it is appropriate for communities to cover any funding gaps with public funds. Others argue that commercial insurance markets should be paying an amount adequate to cover the cost of providing services that are not covered by Medicare and Medicaid. It is important to note that only about 20% of all transports involve commercially insured patients. If commercial insurers are required to pay significantly higher fees to compensate for other payers like Medicare and Medicaid not paying enough, then the cost of funding these emergency services gets shifted to consumers purchasing commercial insurance. This philosophical divide regarding who should be responsible for funding emergency services in communities is the major obstacle that prevents stakeholders from working out any further details about how to address this important issue. So that's a very broad overview of that this issue is a lot more complex than direct pay. And this bill is only meant to address that one little issue and is not going to address any of the other issues related to this.
So for those of us who have been in the room with this issue over the years, your arm down for a second. The issue was always originally balance billing. People wanted to stop the balance billing. The problem would be is if the check goes directly to the ambulance and then the ambulance company bills the patient for the balance billing, the patient will say, no, you got paid. You're all set. So the simple compromise, okay, because originally we had to be paid direct. Issue was always balance billing. The compromise that we originally put in the statute was that it may. Well, the simple answer would be is that if the insurance company, if the ambulance company wants the check directly, they can't balance bill. That would be the compromise. Yeah, I know. I just threw the bomb on the floor, and I want everybody to absorb what I just said. Okay? Now, Representative Gibbs.
Thank you. Yes, I do recall that we discussed this during the hearing, and certainly the issue of balance billing is an issue. But as I tried to explain earlier, balance billing aside, the current system is harmful not only to the providers, which is what we've mostly been discussing, it's harmful to the patients because the patients are put in this incredible complication that seems to me to be completely unnecessary. And that's why I really think this bill is necessary.
Do you understand what I just said?
I do.
Okay, so the patient's not going to be misunderstanding and saying is, why are you balance billing me if you've already been paid?
This could be in the statement, could be explained in the statement. Couldn't it?
So in other words, when the balance billing comes in, the ambulance company has to say, yes, we were paid, we did receive X amount of money, but it's not enough, and we want you to pay the difference.
The cost of we got paid X, the cost of the service is actually Y, and that's why we want you to pay Z. Now, that's not my favorite thing. I would rather not have that happen.
Well, you understand that you're talking about how this is complicated for the patient. So don't you think it would be, the patient would say, no, I'm not going to pay you a balance, but I'm not going to pay that extra charge because you've already been paid.
Well,
that's
okay,
what I'm saying. Is that a compromise?
That problem doesn't always occur. I mean, this has happened to me 3 or 4 times, and there was never an issue of the insurance company paying too little. The provider was always willing to accept the amount provided by the insurance company. The problem was, where do you send the money?
That's what I'm saying to you. I agree with this bill if we add a sentence that there would be no balance billing. If the ambulance company wants the check directly, it doesn't want to go through the patient. If they want the check directly, then they can't balance bill.
Then who is
Representative Spear, let legislators get to speak first. But
When we had when we had the hearing, we heard testimony that was literally scary to me. Yes, in Concord, where the ambulance is pretty close to the hospital and people live close to the hospital, that's fine. And you know the balance, and you probably don't need balance billing. Maybe, I don't know, but upstate, where they're traveling, sometimes we heard stories of having to go out of state to get people to a hospital. I mean, horrendous stories. I don't know how you could ever cut out balance billing for that kind of situation. You know, so I cannot go along with that.
so Representative Purcelli.
Yeah, thank you. I have a few questions. So would Medicare and Medicaid be considered contracts? So who, how does Medicare and Medicaid work?
Yeah.
Do Medicaid pays the provider directly? And I understand that some of the providers are local municipalities. So does that bring another complication into the mix? And I get billed for out-of-network providers all the time. So I'm not really sure why this would be.
Yep,
I'm just trying to figure out. I'm not sure why this particular service would be so much more egregious than any out-of-network provider where I get a bill that has the balance of what the service was and what the insurance company paid and what I'm responsible for.
Okay.
So I'm just trying to figure out those issues. And thank you for at least trying to have the conversation, but I think a lot more work still needs to happen. And I hope you didn't say, well, we tried and that's it. We had a commission, we tried, we're done. I hope you're continuing.
We are open to continuing our work, but the issue's kind of at a standstill where we have all the stakeholders and it's not just two sides. It'd be more like a circle and everyone's on the very periphery. And until they start moving a little bit closer, we're kind of at a standstill. So someone needs to give up something. There needs to be some kind of negotiation on this issue for us to continue. To get to your questions, yes, it is the same for all out-of-network providers. So the provisions in this bill are not specific to ambulance. It's for all out-of-network providers. And it's the same process for anyone. As for respect to billing, billing works the same whether you're a municipality or any other kind of provider. You would send the bill to the entity responsible for paying, and then they pay the bill. For Medicare and Medicaid, there are set rates that are set by both of the programs. Currently in New Hampshire, last year there was legislation passed that increased funding for Medicaid. So currently in New Hampshire, it's the same rate being paid for both Medicare and Medicaid. Traditionally, Medicaid had paid about half of what Medicare pays. So right now, they're equal. That payment that's set by those programs is payment in full. And if the person is covered by those programs, the providers are not allowed to balance bill in those situations.
And the other out-of-network?
Why don't you stay there?
So any other out-of-net, I'm trying to figure
Yes,
out what's
so
the
for
difference between
out-of-network-
this bill and any other
Well,
out-of-network
the example I would
bill.
give is when you go to an out-of-network doctor or physician, whatever, you don't leave without paying. Right? You
I get
don't
a
get,
bill.
you get a, you,
I get a bill.
okay, so they let you out the door without, because usually whenever I've been to an out-of-network,
There's
They-
some
they-
type of
they-
down, like
they're,
a down,
they're expecting payment.
a certain percentage, and then I get a bill for the rest.
Right, but usually, like you say, when I go to Convenient MD or some, they're going to charge me right up front. Well, I'm just saying, any
Yeah,
it-
yes,
normally
I
when you're
think
going
there
out of
are-
network,
They're
they're
probably different. Every
they're
office
charging you
probably
before
has
you go home.
a certain percentage, and then the
Right,
balance.
and that's what the
comes.
issue is that they don't carry a credit card machine in the ambulance.
I can understand.
So every plan is a little bit different. Some plans do cover out of network services and that there could be cost sharing associated with it. Most managed care plans exclude out of network unless it's an emergency situation or sometimes urgent care could be included in that. The procedure for it is the same though, that the patient will be sent a bill from that out of network provider because that out of network provider, whether they're an ambulance, a doctor, or a facility, does not have a contractual relationship with the insurer. The patient then is responsible for submitting it to the insurance if you have any kind of out of network benefit. If you don't have an out of network benefit, then you're likely going to have to pay that full amount. And the patient is the one responsible for it because it's excluded usually from your policy that it's not going to be covered. But some policies do cover out of network, so it just depends on the policy.
Okay. Other questions? Yes, Representative Burrows.
This isn't a question, it's a would you believe? I mean, I just share Representative Porcelli's frustration that, you know, we seem to just, and was on that commission for one day and then stepped off. I feel frustrated that we're kind of saying, oh, well, there's nothing we can do. And I don't know what the answer is either, but it's very frustrating.
Representative Gibbs.
Thank you. This is also a comment. It was just said that this bill refers to all out-of-network providers, but I have it here right in front of me and just looked at it again. And it refers specifically to ambulance providers, not
Correct.
all out-of-network providers.
When she says all, it's not the bill. It is that is the underlying statute that does say that if you're out of network.
Right, but this bill deals only with ambulances.
That's correct. You're choosing just one industry right now. So, anybody else? Okay. Okay. We'll let the sponsor.
Thank you. So I have a couple of points to make. So what's the difference if the patient gets the check, then sends it in, and we balance bill them that way? They still got a chunk of money, whether it went directly to the ambulance or whether it came through the patient to the ambulance. We're still going to balance bill them. They still know what's going to happen. If you really want to make balance billing go away, pay the whole bill. Have the insurance companies pay the whole bill that we're charging them. I still can't really wrap my head around how an insurance company gets to say, nah, you asked for 500, but we feel like we're only going to pay you 300 because I know if my oil company showed up, put $500 of oil in my tank, and I said, I don't really think the oil's worth 500. I'm only going to pay you 300. They're either going to come and suck the oil out or send me to jail. So I still can't figure out how they get away with that, because I call that theft, but that's just me. So they keep trying to use this to get us in network. We can't come in the network. We can't afford to be in their network. We won't survive. And then when you dial 911, nobody's coming. Or if they are, they're coming from a long way away. So that's the decision, I guess, that you guys have to make, whether we're coming or not.
Right, but you're saying what's the difference of who the check gets mailed to?
Right.
So the question is, what's wrong with the system now?
They spend it, and they don't pay the ambulance
That
bill.
they being the patient.
Correct.
So that you're thinking that if you get the check ahead of time, they won't
then we run
they
it.
won't spend
We-
the back bill, the balance billing.
We also run into that. We get calls all the time. I got this. What do I do with it? I don't know where to send this. Where's the address? Where do I mail it? So, if anything, it's helping the patient, especially just been through traumatic stuff. Where do I send the bill? Where do I send that check? Right. So it just makes it easier on the patient.
How about if when you deliver that patient to wherever they're going on, you hand them a piece of paper right then and there and said they can sign off to have the check sent directly to them, direct to another way. How about
We do.
to have that waiver now?
We do. And they still send it to the patient.
So they ignore the insurance companies, ignore that name. Okay, well, maybe that would be a compromise.
You kind of all compromised out.
No, the, the compromise was
I haven't
when we
seen
said
any
you may
compromise
get
on
it.
that side.
We've already been dealing with this issue how many times? How many times have you put this bill in?
This is my first,
Okay, how many times have you come into this committee and
Oh, couple
supported the
times.
legislation?
right? Couple times.
Couple times.
Why? And that's the question. Why do I have to keep coming back? This is pretty straightforward.
Okay, Representative Burrows.
Would it be helpful if when the check comes, there's a big, big piece of paper in bold letters that says, this isn't yours, you need to send it to
No.
the ambulance company?
Do you think the insurance company's going to do
No,
that?
no. They're not telling you the truth. The truth is, you bill, you let the customer, the patient know. You have in their mailbox within a week of the billing that they're going to be receiving the check. You let them know this happening. The problem is, evidently, for Representative Gibbs, she needs to, each time it happens, to call up and say, I don't understand your letter that says, by the way, I'm going to balance bill you based upon whatever you end up sending, whatever that check is.
Mr.
Okay.
Chairman, I received no such notice. And by the way, the
So
reference.
no ambulance company ever mailed you a notice that you might
Never.
be...
Never.
Oh,
And I'm talking
well,
3 or
I'm
4
shocked.
times.
What is wrong
And,
with you ambulance companies?
Mr. Chairman, may I continue? Thank you. Just in reference to Concord, I once had an ambulance take me a quarter mile, and the bill was almost $1,000. And again, there was 900 and something paid to me by the insurance company. And by the way, in reference to signing a piece of paper when they get you to the hospital, the last time I was taken to the hospital was because I woke up at 3 o'clock in the morning in excruciating pain. And I can assure everyone that at that point, I was not in any shape to understand anything that I might be asked to sign. So I don't think that that is really the solution.
I can't believe you were charged $1,000 in the city of Concord.
I've been charged $1,000 in the city of Concord several times. The worst one was when it was a quarter mile because I was in my doctor's office. I had gone to my doctor's office due to repeated indigestion. I'm sorry to make a long story of this.
Okay, well,
but this
here's the question real quick. Was it the city ambulance or was it a private ambulance company?
well, that was the change. It changed from the city ambulance to the private ambulance company.
And
Okay,
both
and
times
who-
they charge you $1,000.
Well, they've charged me almost $1,000 every single time. Okay. But that quarter mile, I was in my doctor's office. My doctor's office was a quarter mile from the hospital. My doctor gave me a test and she said, I think you're having a heart attack. And I said, okay, I'll go to the hospital in taxi. She said, you can't go in a taxi. You have to go in an ambulance. We're calling an ambulance for me. So they called an ambulance. The ambulance took me a quarter mile. I wasn't feeling that bad. I could have walked. But I got a bill for almost $1,000. I am not exaggerating.
Gotcha.
And again, I went through this craziness, and the current system is harmful to the patient.
Okay, Representative Thaxton.
Before I get into my actual testimony, I would like to say to Representative Gibbs, if there is anyone in this room who could walk a quarter of a mile to a hospital while having a heart attack, I'm sure it would be you.
The thing of it was, I was not having a heart attack. My doctor misunderstood something, and I was fine. I was perfectly fine. But the doctor said you have to go to the hospital.
Well, should that happen, I'm sure you'll make it. But I have to put on my selectman's hat. In the 2 towns that I represent, I'm a selectman in the town of Troy. And unfortunately, in New Hampshire, when you become a selectman, you learn things that you never wanted to know. And one of the big challenges that we had is our ambulance service. And so the issue as a business owner, I look at the billing and say, well, why don't you guys just send a bill? And then the answer we get back from the ambulance service is, what's going on here? They send the check to the patient who spends it, or when we send them a bill, they say they don't have it anymore. When you live in a rural area, when you live with people, I mean, is there something murkier than medical billing? I can't imagine what that would be. So I have to say that, well, I would like to think that people would be reasonable and say, oh, this is the check for $900 from my insurance company that's supposed to pay for my $1,000 ambulance ride. The reality in the world is the patient gets a check for from $900 from the insurance company, and that immediately goes to whatever they want to spend their $900 on. As a selectman, as in a town that now we have a joint quasi volunteer quasi joint operation in Troy and Fitzwilliam for the operations of our ambulances, which has been very successful. And we have not had to sign on with Cheshire County's very expensive, unfunded ambulance program. But we still have the issue of billing. And in our case, it's cheaper for the taxpayers of the two towns to subsidize the short, which is largely made up by the short is the billings that we don't get the money back on because they sent the checks to the patients. I don't want to quote our billing, our what we actually are, our collections rate, because I understand it has improved. And the other thing that I think you have to consider is not over here in the big side of the state, but when you get into the rural part of the state, I'm sure up in Coos County it's the same, and I know what it is in Cheshire County. These are quasi-volunteer projects, operations. It's town people, and they don't want to be bill collectors. They don't want to hound their friends and neighbors who just had a heart attack for a $400 check. And when you talk to the guys that run the ambulance squads, they'll tell you that's like, well, yeah, we know they got the money and we know they owe it to us, but now I have to be a bill collector. And that's not what they signed on for. They want to save lives, not collect bills. And, you know, we as selectmen, we have to deal with that. We ultimately get to be the bill collectors. But so for all of those wonderful reasons on my part, I really have to say this is a big problem in small towns. The smaller the ambulance service, the bigger a problem this is. And I would have to support the bill to send the checks directly to the ambulance people. And I don't see why you can't bill the patient for the deficiency. If the bill's $1,000 and the $900 check goes directly to the ambulance squad, they can bill for the $100. And quite frankly, if the people can't pay it, in all of the ambulance squads I'm aware of, they're going to write it off anyway.
Right. So the balance billing is going to be mute because if you mail the check directly to the ambulance, the patient won't pay the balance billing anyways, and so they're still out the money. So
At least they're getting the check.
But they're still getting more money than the 40% of the money that they're getting now.
okay, Representative McAleer.
Thank you, Mr. Chairman. Just again, I do think that sending the check to the person is dumb. We don't do that in other types of medical care. I don't go in and have an operation for a knee replacement and get a $10,000 check. It's paid directly, and there may be a co-payment, and then I pay that. So I don't see why this should be any different. I think the bill makes sense. As our person from the insurance department said, it's not covering the whole thing because there's a lot of different problems, but I think it's a step in the right direction. You'll get part of it covered. So I support this wholeheartedly.
Thank you.
Right. Well, Representative Am just pointed out to me that the problem is that the bank is cashing the check in the first place because the check does say payable to the ambulance company, but that they're still cashing it.
That's
No,
not
it's
correct.
required by statute. In the current law, the ambulance, it's supposed to say the insured and the ambulance service provider. So for the patient to say they don't know why that other name is on the check,
The ones I got were payable to Merrill Gibbs
how long ago was that?
a couple years ago.
Okay, because this law's been on a book. How long we've had with the last time we did this where we put in the ambulance company? Yeah,
I don't think they're coming that way. to be
They're not
honest with
coming
you.
that way.
so you're saying they're violating the law?
Shocker, isn't it?
I guess I need to see evidence of the violation.
I'll try and get you a check.
Okay, I would like to see evidence of the violation. Then we'll have to give it to the ambulance service if it's true. All right. Representative Purcelli, then Representative McHugh.
So, first of all, thank you for your ambulance service. I think we all appreciate, especially the volunteer services that we have. When we call 911, we definitely appreciate someone coming and helping. But I wanted to understand, why is it so difficult to why is it so difficult to sign a contract with the insurance companies? You mentioned that it's too expensive. Can
So-
you expound on that?
Correct. So
And then is there a difference between private ambulance and municipalities with the contracts? And then finally, would municipalities pay the difference if the patient cannot pay?
okay, let me see if I can get all three of those. So, yeah, no. What was the first one? That was-
About, you mentioned that it's too difficult to sign
Oh,
up.
so if we take what they offer, because usually it's not just $100. It's usually
Well, I
about
mean,
half the bill.
signing a contract, what you mentioned, it's too complicated to sign contracts with
and-
the
and
insurance.
They're
I'm getting
just
there.
not getting enough. They're not getting enough.
So if we
No,
sign
but-
the contract, we take what they give us and we cannot balance bill. Not because we want to, right? It's a federal law. So we can't get around that. It's the law. And yes, we lose money on those patients, right? If you notice, there's a lot of doctors that don't take Medicare and Medicare patients anymore. And that's why, because they lose money, right? So we don't sign the contract because we don't want to lose money again. It's bad enough we're losing it with the feds. So we can't balance bill if we take that contract. That's why we don't take that contract. And your next question was?
Yes, I wanted to understand, so if the patient cannot pay and it's a municipal
So if the patient
ambulance,
can't
does it go
pay,
back to the town? How
so
does that work?
and I can only tell you how my town in Epping does it, right? So if that patient has received the check, has cashed the check, hasn't sent us the money, but we know they received the check, we will send them a bill 3 or 4 times and then maybe put them into collections. If they did not get a check or they sent us a check and we send them the balance bill, we will bill them 3 times and then the town writes it off.
It's similar to what you're doing with Medicaid and Medicare.
Correct. So, but we're trying to survive, right? And the difference between a private ambulance and a municipality, if the private ambulance is not doing emergency contracts and just doing transfer work from one hospital to the other, the nursing home to there, right? Those are pretty much scheduled calls. They know they're going to be busy all day. So even at that lower rate, they're making up in volume what we can't make up in volume, right? So they do better in their volume, right? Where we sit around ready, not just sitting around, but we're working and ready to respond. But if we don't get 4, 5, 6, 7 calls that day, we're not making the volume, right? We may only get 1 call that day, and you've paid a crew of 2 minimum to be 24 hours. And now we have to pay pretty substantial, especially like a lot of departments hire people during the day because the volunteers of old aren't here anymore. right? They're working. They may not be able to work in town anymore. They have to leave town, so they're not available for calls. Looks like somebody had an early morning call. No? Oh, okay. But so we end up having to pay people now because, like I know in the town of Epping, the people that would take these volunteer jobs can't afford to live in town anymore. So we end up having to pay pretty much 24/7. So that's what we're trying to do. Just
Okay.
stay afloat.
Representative McGee.
Thank you, Mr. Chairman. So a few thoughts on this for the committee. EMS has been my career for a long time. Some of you already know that. Private, public, volunteer, whatever. And the issue here is helping these EMS services be sustainable so they're available for the most number of people in the most solvent fashion. And, you know, insurance companies have had a chance to do the right thing for a long time, and some do. And some services are able to sign a contract, but some aren't. And many patients, like Representative Gibbs, who are very capable of getting themselves to the hospital, may feel compelled to utilize those services and then get stuck with the bill. Point of fact is you always have the ability to sign off or sign a refusal, as we call it, you know, the vernacular is a refusal of services. But you very well may be pressured by your PCP or the providers themselves to say, well, you know, we're not responsible for what happens. You could die in 5 minutes. Or, I mean, you get the idea. So a lot of patients don't sign that refusal. And of course, in that type of life circumstance, don't read the fine print that says, you know, where you sign consent to be transported, which I assure you that you do. Like, it has to be in every EMS run sheet. It's got to go into our state system. You've got to sign, or it's documented why you didn't sign, like you're unconscious or whatever. And if you're unconscious, it's implied consent. So you're taken, right? So, but you have to give consent to transport. And when you do that, you are absolutely on the run sheet signing consent to be billed, right? Similar to when I call, maybe it's a bad analogy, but it's close. If I call Portland Glass and say, will you remember we did the windshield bill here? You know, I call Portland Glass and say, will you replace my windshield? They Geico gave me the option of sending the check to me or sending it to my dealer. Well, I didn't want to have to handle that money. Didn't know exactly what it was going to cost. I told Geico, send it to the dealer. As it turns out, they didn't. They actually sent it to me. And the dealer called and said, where's our $3,000? And of course, I hadn't cashed it. It was made out to two parties. I just signed it over and gave it to them. That doesn't always happen. As Representative Prue has said, and he and I have been in the EMS service for about this, well, I've been 33 years. You probably got a few years on me, a couple. So we see both sides of this issue. And I think now, since 70-80%, I don't know the current number of EMS are provided by volunteers in the country and in our state. Now, some of the largest call volume areas, in fairness, right? So if you can look at that 70-80% number two ways, the number of calls done by volunteers and the number of staff, right? So some of the busier cities like Manchester, Nashville, Concord, some others are staffed by full-time folks that have medical billing as part of their service, and they can go do the collection. Plenty of towns, just like Representative Thaxton said, don't want to harass their neighbors. They don't want the town clerk to be in the billing collections. So they employ a billing or collections, which then takes a cut, right? And that makes it a less valuable proposition. So frankly, we ought to pass this bill, right? And I'm not always on this side of this type of thing. Representative Hunt knows that. Maybe that's why he kept looking to the right and didn't want to call on me. But anyhow,
Dale had something to share.
okay. Anyways, I think we ought to pass it for those.
What we're going
reasons.
to do is we're not going to take any vote right now. When I read the bill, and it just crosses out the check payable to the insurer and the ambulance service provider, and then it goes on, subject to the terms and conditions of the policy, plan, or contract. So since there is no contract, I guess that means is that the insurance company would be up to saying anything they want to say in the terms of the policy. And wouldn't you be surprised that next year they come back and say something that you didn't really want them to say in that policy requirement? Because they might say in the policy, our policy is not to pay the ambulance, or something. I would like to see a copy of a check, recent check, that did not have the service provider, the ambulance, on the check. Because if there is a violation and the insurance companies are violating the statute that we just passed, I realize hasn't been on the books that long, but I would like to know if there's a violation going on. But notwithstanding is, I think we might need to look at the finished part of that sentence if you really want to pass this bill. Okay? So, all right. Thank you very much. All right. Next. 1094. Oh, pandas. Yeah. Yeah, we're ready to, this was ITL because yeah, okay. Right? That's what the sponsor wanted, right? And Macbeth. Right. Okay. So who would like to make the motion? ITL. Yeah.
I will move
Okay.
to ITL this bill.
Okay. Okay. L. All right. Moved by Representative Porcelli, second by Representative Thaxton. Any discussion on the motion of inexpedient to legislate? See none. The clerk. We don't. All right. Seeing. Yes. Anyone want to speak to the motion of ITL? We're doing no 1081. We're passing over because right now 1081. Even if we were to pass it, we have to. The bill's going to need to be amended.
You want to designate a substitute for Vincent?
Oh, yeah. Right. Oh. So do you have a replacement for Vincent?
That's
Okay, Mackler.
me.
Okay. Okay. So the motion is so we have this is and then I'm missing Terry, so actually it doesn't matter.
Okay.
So
No, subcommittee.
okay. So at this point we'll just just have them pair each other. Okay. All right. So that means it's Porcelli, McGee, Hunt, and Calabro, Gibbs, and Burrows. Okay. All those in favor of inexpedient to legislate, raise your hands. Okay. 1, 2, 3, 4, 5, 6. 6 is it. I'm pairing you, Chris, with Terry, who's your seatmate, who's not here.
All right.
Okay. All right. Next one, 1236, relative to repealing the Commission on the Status of Health Coverage Markets for Individuals and Small Employers. Oh, I think this is my bill. Okay, so this is a commission that never met, and its mission is sort of gone by. So I'll move inexpedient to legislate ITL. So, anybody want to second my motion for me? Okay.
Yeah, 1236, you got OTP that?
No, ITL. Oh, excuse me. Oh, that's right. That's right. I want to pass it. I'm sorry. Yes. OTP. Excuse me. Ought to pass. I don't know. What am I thinking? What am I thinking?
Everybody slow down.
Right.
Repealing.
Okay. Right. I forgot the key word. Repealing. Okay.
You just
Is
like
there
to kill bills.
Any discussion?
Kill any bill, even your own.
That's right. I just can't help myself. Okay. Is there any more discussion on ought to pass on 1236? Seeing none, all those in favor, raise your hand. 1, 2, 3, 4, 5, 6. Okay, 6 0. All right. Okay.
Right here.
Just the,
Insurance coverage for diagnostic and
oh, right,
breast
right.
exams. And we do have one.
Okay, department, insurance department. Is this one that needs to be reviewed? It would be need to be reviewed. 1296. Do review and find out what the financial impact under
I'm sorry, what's the question?
yeah
Exactly.
about well we have to do an impact financial review.
A fiscal note, yes. We are in the process of, we had initially submitted a fiscal note for 1296, but in preparing for today, we realized that there was a mistake in it. So we're in the process of updating that fiscal note. The issue with this bill is it's trying to mandate, it's requiring the coverage of diagnostic and supplemental breast examinations without cost sharing.
Right.
So under the current system, preventative services, just to be clear, these are all covered services,
Right.
but preventative ones are with no cost sharing. Currently, there is some cost sharing that is allowed for the diagnostic and supplemental.
Right.
So to remove that, there will be some fiscal impact, and we're in the process of amending it to kind of peg down exactly what that fiscal impact would look like.
Right. And
Because
then,
it's shifting
and
the
then,
cost from the patient to the insurer. So
and
the
then
insurer's
if it's-
responsibility.
if it's under the Medicare expansion, would that now require the state having to pay for
No,
the
this
co-
would not have any defrayal implications.
Okay, so this is just we're now using what I call the Murphy law, which we usually would hold the bill, an interim study the bill, and then we would do that financial analysis. But you think you're going to be able to do that in the fiscal note?
Yes, so defrayal would only apply if this was a service that's being added. These are already covered services. The only thing that would be changing is that there would be no cost sharing for the patient. So whatever amount that patient would normally have to pay under their policy, the insurer is now going to be responsible for. So there would be a slight fiscal impact, and we're in the process of nailing down exactly what that's going to be, but there is no issue with defrayal in this case.
Okay. So, and then the other question is, in my mind, was what can of worms we're opening up in terms of other potential services like this. So when you say these are, you're defining the difference between the right now what is free, which is the what was the term? I need to write these terms.
Preventative care. So under federal
Preventative,
law,
right.
preventative services as defined by this federal group as preventative, that there's
Right.
clinical evidence to support this, those services need to be provided without cost sharing.
Got it.
All other services in your medical plan are typically covered in some way by cost sharing. So it could be subject to deductible. It could have
And so what do you
co-insurance,
call those? Do
copay.
you have a code? What do you just say?
Cost sharing.
Cost sharing. Okay.
Cost sharing.
So,
So depending on your benefit design, that's how much cost sharing you'll have to pay. So if you're
Right.
thinking of the tiered plans in the silver, gold, platinum, bronze plans, the difference in those plans is your amount of cost sharing. So you may have 30% cost sharing or 20% cost sharing or 10% cost sharing, depending on what level, metal level you have. So that cost sharing amount, and every plan's different. So it could be a copay, it could be co-insurance. So it's kind of hard to peg down an exact number about what this would impact. But yes, to your thought about how this could kind of this slippery slope argument, these services are diagnostic, and like all other diagnostic services, they are typically subject to some kind of cost sharing.
So-
This bill is intending to carve out these specific services so that there is no cost sharing.
so I should know this, but I don't. What's the difference between co-insurance and deductible and copay? What does co-insurance
So
mean?
your deductible is say you have a $1,000 deductible.
Right.
You're going to have to pay that $1,000 before all of your services are going to be covered.
Right.
Without
And I
cost
know what
sharing.
copay
Yeah.
is.
So the copay is you go to the doctor, you're going to have a $30 copay.
Right.
That's
so
what
what
you,
is coinsurance?
So coinsurance is if you don't have a copay, sometimes there's a coinsurance. So it'll be 10% coinsurance or 20% coinsurance.
So rather than
of
a
the
fixed dollar
contracted-
amount, it's a percentage.
Yeah, it's a percentage. So
Okay,
if the
okay.
contracted rate is $100 and you have 20% coinsurance, you're
Okay.
responsible for $20.
Okay, so I put dollars over copay and percentages over coinsurance, and
Yes.
now I know the difference. Okay, so the question then is, in terms of this particular issue, was that it seemed that this one of the part of this discussion was that all right, we get the free mammogram, we get that have that. Now they have they're not sure. They're not getting, and so then we're going to now send you off to get this more expensive MRI. But that technically could be still preventative because, well, I'm just saying in my mind, it still could be preventative because we're making sure that what we didn't see or could see were the first free one, that we now want to drill down and do better. Okay, so then we would be in terms of a comparison to other cancers. Okay, so if they do I don't know, maybe a colonoscopy, which is free, and then they say, well, we're concerned whether you're something else. So I don't know where they get to find other when the thing is metastasized and moved around, but in other things where in terms of cost sharing, one is actually we're trying to help you cure you. We're trying to go in there and we're going to start pulling things out, the tumors out, versus we're still not really sure whether you do have breast cancer, right? So in other words, if we were to narrow this bill to that one MRI that is a follow-up from the mammogram, is that possible? Could we do it? Is that to just simply say that if it is it's only a follow up, but then any other if going forward the decision is to do that all bets off, it's still the cost sharing, but that
Yeah, so the way it's written now, there's nothing wrong with this language. Or if you want to limit it in some way, you
Well, I
can
would
do
just
that as
did-
well.
what-
It's just
right.
going to come
What-
down
what
to
I'm
what
afraid
the
of this
fiscal
language is
impact is going to be.
That's right. I'm saying my fear of this is that we've opened up the door from all kinds of other Me Too's, that we too want to get rid of the cost sharing deductible. And let's face it, the whole reason we have high deductibles is because people want to have a lower premium. So when you start getting rid of deductibles, you're
Yeah, it's all
messing
it's
up
all
the
a balancing
balance.
act.
You're messing up the balance
Yeah.
by start picking it, pulling things out. So I was just focusing on the fact that we have this, we have these two things, colonoscopy and mammograms that are free. And so if it was really true, if this issue, if we just were focusing in on to ensure that we really are making the right diagnosis so that you get one free one.
Yeah, I mean that's an option that would be for the policy
Okay.
makers to
All right.
make.
So now I'll open up to the committee members and hear what other people are thinking. Yes, Representative Pertelli.
I guess I have a general question about more information. We seem to have a lot of bills related to requiring insurance coverage. So I'm trying to figure out, what is that list that we already have? And then I'm sure that will be added to every year. And then, the cost sharing issue. So these are the two areas, regardless
yeah.
of what the health issue is. I just see both lists growing. And then how do you determine which one goes on, is eligible for the insurance coverage and the cost sharing, and which health issue is not? It gets to be very complicated.
That's a good question. It is true, and I meant to have Kristen do one up. The last time I did it, it was Pam Smarling was still our committee researcher, and she was maintaining the list for me. I would say after the Affordable Care Act passed, we've seen a reduction in health insurance mandates because of this requirement that the state might have to pay for it if it's a new mandate. In this case, I would say I was in the room for almost all 40 of them. When I first got on this committee, the only mandates we had was the first one was whether social workers can provide mental health coverage. That was mandated. That shows you how long ago that was. But yes, I think that's a good idea. I'll get that list for everybody. It's an amazing list to see all the things that over the years the legislature has dealt with when it comes to mandates. So, but yeah, Representative Burrows. Yeah, right.
I just want to say that, I mean, I thought we heard really compelling testimony from doctors, from patients, people and other people in the field about women not going to get the follow-up exams because of the cost, because of their families, because of missing work. And I think that this one is just too important not to just pass by. And I think it's important that
Right. Well, I'm not passing it by. I'm just saying I don't want to give a free get out of jail. I mean, how many MRIs do you want to give away? In other words, if you're saying that one of the questions was that once you've had an MRI,
Yep.
then you don't get the free mammographies anymore. That was what one of the comments was. You don't get them anymore, and that everyone has to be the MRI from then on out.
Well, but you do need follow-up once you've been diagnosed.
Well, that was right. Well, okay, but then you're a cancer patient. So are we going to say that every cancer patient, not just this one, should get free MRIs?
What do we do when other patients get follow-up for cancer?
I'm just saying, when it comes to cancer, I assume all MRIs. I assume they're doing it by MRIs, but some of them might be just ultrasounds. I don't know. Or they do a biopsy is surgery. I mean, that's even more money.
Mm-hmm.
But I'm sure they have to pay for that.
But,
Yes.
But you lose, oh, I'm sorry.
Yeah,
Thank you, Chairman. I'm sorry. It's diagnostic imaging we're talking about. We're talking about surveillance imaging. That's a term that we use.
Right.
When we have somebody with an illness and we're trying to just surveil it. We know they have the cancer or that they're at risk for it.
Right.
We demand that they do certain things. The insurance companies will cover those modalities. The problem that we're having is there's a gap between affordability here. It is in the insurance company's best interest to address their proper care. If we continue to just ignore their orders or to continue to believe that these patients are going to just suck it up and pay for the diagnostic imaging, you're mistaken. What ends up happening is they end up not going. They end up ending in the ER. I end up getting the progress notes from the ER.
Let me just cut you off. So you're saying we should do this for all cancer patients?
I'm saying that we need to allow insurance companies to make better policies. I don't want the general court to get involved here, but when they're not.
Well, we're involved. That's what this bill is.
Yes.
Are we going to say no more deductibles, copays for cancer patients?
No, this is just a recipe.
No,
This
that's
is-
today.
This is surveillance.
That's today. Rolly will be back next year with another one, another cancer patient. This is today. Today is just this particular, breast cancer, but, prostate cancer, you name all the cancers are out there that I'm sure they use these MRI machines for, right?
I think you're not looking at the big picture here, and that is that there are more and more providers that are trying to fight insurance companies to get these things done. And they're not getting done because of that reason. These people are going to die.
Okay, I hear you, but are you ready to pay the insurance premium for every cancer patient to get all these MRIs for free?
When we're avoiding the long-term cost of emergency visits over and over again because they've been avoiding it, yes.
Okay. Representative Purcelli.
What I have in my notes is that once you're diagnosed as a cancer patient, then you are ineligible for the yearly
Right,
test.
exactly.
And then you have to
That's what we
pay
heard.
for your test. So I wanted to understand I'm not sure why we are enabling the loss of that yearly preventive test now that you've been diagnosed. So should that still be
Right, well, that's where I was getting
available?
into, is that if
So you get the one
to get the
each
one.
year, and then if there's other tests that you would need, that would be subject to your insurance.
So
But you shouldn't lose your preventative test.
you shouldn't lose it,
because
right?
you're
Because you might not need it.
diagnosed.
You might let's say this preventative test came back negative. okay, that it was a shadow. It wasn't as bad as it was. But if what we heard from the testimony was then they have to be getting this MRI forever.
No,
That they
I
would
think
they wouldn't get the
once you're stamped as a cancer patient, the way I have it in my notes is that
Okay.
you're not eligible for that yearly
for,
preventative
free,
test.
which doesn't make sense, right?
It does not make sense to
Does
me.
not make sense.
Right.
Right. Okay. Anybody else? Representative Spear?
Having multiple breast cancer patients in my family, the reconstruction usually eliminates the ability to get, often eliminates the ability to get a
Mammography.
mammography. You have to
Right.
go for
You
an
have
MRI.
to go for an MRI at that point.
And having had a sister that's had it twice, I don't know. I feel bad about cutting that out afterwards, not making it free because she waited 10 years before she did anything. And then it became a very big deal because she didn't have the money to get the MRI. So
Okay.
I agree with you. I think we need to do it.
It's buy now or pay
So
later.
when you redo this fiscal note, are you calculating the free, if that this would be forever for any patient? That once they've been diagnosed with cancer, that if the
I think there's a little bit of a misunderstanding about the preventative services. Preventative services are meant to help screen patients that would otherwise not be screened to catch things early. Once you have cancer, you're at a different level. We're not doing these preventative screenings to make sure you're getting it caught early. You're, like you said, once you're a cancer patient, there's a different level, a different standard of care that's applied to you. So when we do our fiscal note analysis, what we're going to be looking at is how much for these specific imaging that's mentioned in this bill, which is specific to breast cancer. So we're talking diagnostic and supplemental breast screenings. Of those that are subject to cost sharing, how much cost sharing is being paid by the patient, because that is what's going to be shifted to the insurers now having to take on that complete responsibility. And that is what we'll be doing the analysis on to see how much of an impact that is.
and that would assume forever, right? That patient was going to have that more expensive MRI every year.
We would have to do much bigger modeling for that, because what we're looking at is claims data for a year, assuming, there's so many women getting these screenings
Right.
in 1 year. Say there's 1,000 of them. How many of that 1,000 are doing the diagnostic and preventative? That's how we would be modeling it. If you want to do more of an
So-
actuarial analysis of the overall risk and how that, we would have to do some kind of mandate study for that.
The mandate study. So, because the issue is, so you're saying you're just going to look at
Just the cost sharing
the
for
cost
these
sharing
specific services
of getting an
in
MRI
1 year.
in 1 year. And so theoretically, that should pick up the people who have been getting it multiple years in past years.
Yes, if they had one in the last year. I think there's some other aspects to this that you don't really want to gloss over, because the amount of cost sharing you have to pay is highly dependent on the type of plan you have. If
Right.
you have a platinum level plan, the amount you're going to have to pay is a lot less than someone in a bronze level plan.
Right.
So that's a huge factor in this is there's a lot of different plans out there, and the amount of cost sharing you're going to have to pay for not just this, but all your services is going to depend a lot on that plan. So if you were in a bronze plan and you find out you have cancer, the next year you move up to a platinum because you're going to have a lot of health costs, that's not going to be captured in the analysis that we're doing. So there's a lot of other factors that go into this. We're
That's-
strictly looking at the cost shifting of the cost sharing to the insurers.
Yeah. So we don't know how much adverse selection is this mandate would cause. This mandate could cause.
If you want to
adverse
look at
selection.
more long term and some of these other issues that we're talking
Well, that
about,
would be-
it'd
but
have
that
to
would
be a
be-
different type of study that
that
we
would
do.
be pretty complicated to figure
Yeah,
out.
so we would need a lot more time to do something like that.
Then we'd have to do a mandate study.
Yeah, something like it's not really a mandate because it would be just a cost sharing, but
Right.
we're talking about a lot of different issues being thrown out here. So if we wanted us to do some kind of study about that, we'd
Right.
have to have, clearly defined what you're looking for. If we're talking about long-term effects of, out of pocket for cancer patients and what that means from, that's a much different study than doing a fiscal note for this bill.
Okay. All right. So you'll have that fiscal note.
Yes, we'll try to get it over to OLS today.
Okay. Great. All right. So we'll put this off to, unless anybody else has anything else they want to offer up, we'll put this off to some other time. Okay. Yeah, Catherine?
Yes.
Yeah, so this is just a subcommittee. You know,
I
I mean,
wanted to clarify, I hope as the prime sponsor, I can clarify just 2 points.
sure,
if I may.
yes. But yeah, in general, with a subcommittee, you don't put a pink card. You gotta,
Okay, I
you
also-
gotta-
I appreciate that. I don't have this in transportation, so I'm not as familiar. Thank you. I just wanted, as a prime sponsor of the bill, there were 2 points I wanted to make. I know the concern about the slippery slope. It's difficult to talk about who should be entitled to coverage for different conditions, but I wanted to reiterate from the initial hearing that we have the 4th highest rate of breast cancer in the country. It is incredibly prevalent, and yet only about 16% of patients need to have this diagnostic or supplemental imaging. So there's
Say that again, how many?
about 16% after their
16
mammograms need to go on to have the supplemental or
Okay.
diagnostic imaging. So while there is a lot of reason to catch early, it's actually a smaller number of people needing that follow-up. So that limits the cost. And I also just wanted to mention, in terms of the continued diagnostic testing after you've had cancer, I think it's about 5 to 10 years that you would need that sort of skipping over the mammogram and going to the diagnostic imaging. It's not forever.
Okay,
You'd be
but
that-
but it's too confusing. You gave 2 stats there.
Yes.
They actually are confusing to me because you say, okay, if we're the 4th highest in the country.
Mm-hmm.
That would mean we have a lot of people who have breast cancer. And then you said, but only 16 would need to go on to get this MRI.
I realize that they
It's
are
16% of
opposing.
that.
So my
Okay, and
point
then
being, this is a very common cancer, right? So when we're talking about how do we, I guess, weigh what sort of procedures or testing and among different conditions or different cancers we want to be considering, this is something that's really, really common in New Hampshire. That being said, it's still a small subset of people that need to go on for this extra level of imaging or supplement. So it does limit the cost in that regard.
And that would be another 5 to 10 years.
And then it'll be 5 to 10
until-
years.
until they're out of the woods.
That is my understanding. Yes.
Okay. Great. Thank you.
Yes. Thank you.
Any other? Okay, great, thanks. All right, let's move on to the next one. No, that was what we just did. Okay, 1225. Prescription Drug Affordability Board of Conflict of Interests. Okay. So. Right. So, we found that, or I guess my researchers found, I just got something from her today. She said that this conflict of interest and who has a conflict is all over the board in terms of who does for different boards. There are different rules and regulations around it. But she said no one has it where just one board member has that decision, even though the Attorney General, the way the bill's written now, is the AG appointee. Do I have this right? Do I have the right bill?
Are you asking a question?
Yes, I'm asking you a question. This is a subcommittee. Yeah, so you can come on up and speak.
Hi, I'm Representative Jess Edwards. The original bill identified a problem that in the Prescription Drug Affordability Board Act, conflicts of interest were prohibited, but there were no provisions for what to do once a conflict was identified and how to go about removing somebody with a conflict of interest. So the bill as introduced attempted to begin that conversation and provided a way of doing it. And you're referring to an amendment, and I'm less familiar with the amendment. The amendment may have been offered by Representative Merchant, and that's why I came to the subcommittee today to listen to your discussion, because I'm less interested in how the tactics of working through the conflict of interest. I just as soon follow whatever standard approaches the state might use. What I'm really concerned about is that there is no provision for removing somebody with a conflict of interest, and that's a flaw in the bill. And I suppose I could have done better homework before presenting it to the committee, but I believe that this committee, with the jurisdiction, would have some wisdom about the other ways in which we handle such a problem. And so I threw it over the transom, Mr. Chair.
I gotcha. Okay, so if you were compared to our conflict of interest, I believe that it's up to us individually to make notification to everybody that we have a conflict, but that in that form we can check off and say, but we're still going to participate or we're not. But at least we made the disclosure to everybody that there is a perception that they might have a conflict of interest. Yeah.
Oh, we could do it that way. I would choose to go more on offense, because this board is very small. It's only got like 5 people with some alternates, and this board has tremendous power to demand from the market very specific proprietary information that has high commercial value. And because I think the threat from somebody who's unethical being on this board is significantly larger than having one of 400 of us running around, I would want there to be a more difficult standard for that individual remaining on the board. I would want a way to remove them.
Okay, so if I read this bill, your bill correctly, it's the governor and council removes the person. Is that correct?
Yes, I thought that there should be some authority, and I didn't know where to put it. And if the committee sees a better way of doing it, I am fully in support of the smartest way to do this. I just don't want to go naked with this much commercial value potentially exposed.
Okay. Fair enough. Any questions from the committee? Representative Gibbs.
Thank you. I'm certainly not speaking in favor of conflicts of interest, but I'm just curious, and my apologies if this was covered during the public hearing, because I actually don't remember whether it was or not. Do you have any reason to believe that there is a problem of conflicts of interest with the Prescription Drug Affordability Board?
I'd say in general, whenever you allow people access to very high value data, it is wise to assume that there will be people who will abuse that trust, and that you should anticipate rational ways of removing the threat so that the security of the data and the integrity of the board is preserved. So I'm not saying that there's anyone now on the board, but given that this is a brand new board and it got set up rapidly and prematurely, I think we left some things out. And so this is one of the things that I think we left out that we should put back in.
Well, you didn't leave it out. It's actually in statute right now. There is a conflict of interest process in the current law.
Yes, sir, but there's no removal process. And so what this bill intends to do is to create a methodology to remove somebody that has a conflict of interest. It's one thing to say you have a conflict of interest. It's another thing to say you have a conflict of interest and you can no longer serve on the board and have access to highly confidential, valuable commercial information.
So if I read the current law, it's basically what we do for ourselves. You identify that you have a conflict in a 5-day period in advance of the meeting. You're supposed to announce that you have a conflict, but there's no you want a process to get them off.
Again, to protect the integrity of the board and protect the integrity of the expensive information held by private citizens, I think yes, we need to be able to be proactive.
Okay. Yes, Representative Hammond. You go ahead.
Thank you. I'm not on the subcommittee, but I do have a question, Representative Edwards. How would the process work with the governor and the council? Would they make a motion, take a vote, and it would be a 6-way vote to remove someone? How do you foresee that procedure playing out?
I did not. Thank you for the question. I didn't get very deep into how the procedure would work. I put an approach in the bill, and I'm open to how it could be done. And if for some reason the subcommittee decides not to try to fix this bill and isn't happy with the bill as is, I will regret that I didn't put more time into it before it came to the committee and work on it in the future. But I would like to have it fixed by the committee.
Okay, Representative McAleer is next.
Thank you. I'm rather curious. Who would appoint this board, and what kind of people would make up the committee?
The Prescription Drug Affordability Board is already in statute, and the methods of who appoints which member is already in statute. What this is saying is in the bill, there is a provision saying that there shall not be conflicts of interest amongst the board members. What the bill before you intends to do is to create a mechanism to remove an appointed board member who has been identified as having a conflict of interest. So the law is silent on the removal aspect.
No, I understand that, but I'm assuming you're referring to things like insider trading. Is that correct?
That could be an example, or it could be somebody who just has some other vested interest, or opens up a side shop on consulting, because this information is extremely valuable and could make somebody a lot of money in the consulting field.
Representative Porcelli.
Thank you. So who has jurisdiction over this board? So who initially appoints, and then I'm sorry, I keep thinking org charts, but we don't have one here. So who ultimately does this board respond to? And who has jurisdiction? Who
The
gets-
appointments are made, the governor, president of the Senate, speaker of the House.
They
Appoint,
appoint, but
they
they would have
appoint the people who are on
jurisdiction
it.
over
Yeah.
this board. So would they be the appropriate mechanism for removal?
So one of the weaknesses of the initial statute, in my view, and to your point, is that this board is highly autonomous. Once it gets going, it's highly autonomous. It really reports to no one. For example, even though its budget,
It has to have accountability to somebody.
well, I'm going to try to explain
Thank
some of that. So to the extent even that it has a budget, the budget goes through the commissioner of DHHS, but he or she does not have the authority to change the budget. It's just simply an administrative transmission of the request of the board for it to go into the budget cycle. And prior to HB2, the finance committee didn't even have an opportunity to take care of the budget. So this board, once it's established, and it has already been established and been running for a while, it runs very much on its own. And anytime I don't know. I'm just a cynic. I think that if you have too much power consolidated in a very small group and you have no checks and balances on it, you run the risk of abuse. And so one way to rein in the abuse, in my view, is if there is a conflict of interest, have a mechanism to swap that individual out, because the board is very powerful and very independent.
Okay, Representative Gibbs.
Thank you.
Yes.
Am I correct, Representative Edwards, that you sponsored a bill last year to abolish the Prescription Drug Affordability Board?
I submitted two bills. One of them abolished it, and one of it amended the board significantly. And I provided the option to this committee for debate and discussion. So you debated two of my bills. One was to improve and fix the problems that I identified in the board, and one was simply to abolish it. So I should add that I'm now a member of the board. I was appointed in August to this board, and so at least now I have an insider view of the power and role of the board.
A follow-up to what you just mentioned earlier about the budget. So the board now has a budget which will be in the biennial budget every other year, and therefore the budget would be controlled by the Finance Committee. So in that sense, the board is accountable to the Finance Committee and ultimately to the full House and Senate.
More so than it was, and I have to actually go back and double check with my budget assistant. I don't know if the provisions of HB1 or HB2 rather were constructed for this budget cycle and then expires, or whether it's got the continuing nature of law. So I should be able to answer your question better, but I don't know the permanency of what was done in HB2.
Okay. So, yeah, Representative Post, sorry.
Sorry, this is just a clarification. So we did have Rep. Merchant's amendment, but we're not looking at that. We're still looking at the original bill.
We're still
Is that
talking about
correct?
the original bill. Yeah.
Thank you.
So, people feel they have a vision here? Anybody feel one way or the other what they want to do about this, or we could put it off and think about this for another week?
I don't think we have an answer yet.
We don't have an answer. Okay, we'll put this one off. Yes, Representative Hammond has a question.
Thank you. Just a question. So the amendment that we haven't considered puts the auspice on the Attorney General to determine what a conflict of interest is. It also removes the cohabitation language that's in the earlier part of the bill.
Removing the cohabitation language is just fine with me. It bugs me that married people get hit with this and the cohabitors don't, but you can strike all the cohabitant. I don't think placing all of this at the AG's office is the right way to do it. That was Representative Merchants. He chairs the board.
Right. And like I said, nobody else has ever done that before. So, but it goes back to the way the statute's written now. It's the same conflict of interest that we all abide by, which is disclosure.
So I'd be happy if their subcommittee meets again. I'd be happy to participate.
Okay, great. Yes, Representative.
Thank you for taking the question. Would somebody who gets financial support from like a pharmaceutical industry to when they run for office, would that be a conflict of interest to be on that commission?
I'm outside of my subject matter expertise, and so I'll just disclose that on a personal level, I would consider that a conflict of interest, and I would personally disclose it, but I'm a highly ethical individual.
I would think that if you were getting a check from a pharmaceutical company, you would have to claim that and make everybody know. Right. Okay. Great. Thanks. All right. How are we doing for time? Okay. So, I just realized that I had property and casualty down here at the bottom that I don't, we're not going to get to you guys. So I'm sorry you're here, but then this is not going to happen today, I don't think. Okay. What's that? That would be great. You could show me offline. We're not going to take it up again today. Okay. Today is not today. We're going to then forward that to me. Yes, please. Yes, forward it to me. So what you have is a check that didn't have the ambulance company on it. And what insurance company was that? Anthem. It was Anthem. Okay.
Do you want to talk about that at all anymore?
No.
Okay.
I don't. I wanted send that to all. Just type in House Commerce and get it all to us, so we all can see it. Okay.
Mr. Chairman, I have a question while we have Representative Prue here, though, if you don't mind.
Why is he here?
No, I have a question while he's still here.
Oh,
relative to that, if you don't mind.
You can go ask him out in the hall.
No, it's for the
okay. We're not in that subcommittee right now. No, I'm not. This is not a free for all. Okay, next up. Actually, this is the last one I think we're going to take up because I guess this has now turned into a problem. All right, 1365, substitution of biological products by pharmacies. So we have somebody here from the industry who will tell us why we should not pass this bill. At this point, I what's after this? Yeah, I think this will be our last one for this morning because it's almost noon. So
elderly couples here for that bill.
the glucose. All right, go ahead.
Good morning, Mr. Chairman, members of the.
Actually, you know what? Are you locally? Are you local, or where are you from?
Just outside of Boston.
Okay, so that's not local. Okay, go ahead.
Well, thank you, Mr. Chairman. Thank you, members of the committee, for allowing me to be here today. I work on behalf of Amgen. We're in opposition to House Bill 1365, which looks to expand upon the biosimilar substitution statute found within the Pharmacy Practice Act that was passed and signed into law back in 2018. I work as part of Amgen's state government affairs team covering New England. As background, Amgen is a biotechnology company backed by 40 years of experience in the research, development, and manufacturing of innovator and biosimilar biologic medicines. Amgen is a global leader in biosimilar development with 5 biosimilars, and one of our biosimilars is designated to be interchangeable as part of our portfolio, and more biosimilars currently in development. Amgen does not believe this proposed change to the New Hampshire Pharmacy Practice Act is appropriate for legal and scientific reasons. Before I get into the reasons why we're opposed to the legislation, I thought I would just take a quick minute, kind of like a one-on-one, to talk about the differences between biosimilars and interchangeable biosimilars, and kind of what the designation is, and to talk about the differences if the committee will allow. Biosimilars are biologic medicines that are highly similar to and have no clinical difference from brand originator biologic medicines. Biosimilars can also provide lower cost treatment options for patients. And you can look for data and trends that biosimilar utilization is significantly increasing, which is helping drive down patient costs for these specialty medicines. But it's also important to note that biosimilars are more complex than generic drugs and are subject to different legal requirements. So biologics and small molecules, which are pills, generics, completely different, totally apples to oranges. Biologics are injectables, And the manufacturing has to be so precise on all of these biologics that patients are putting into their bodies. It's completely different than with a pill where you follow a certain recipe. And that can be done 100% of the time for all of these generics. An interchangeable biosimilar is a biosimilar that the FDA has determined meets additional criteria that manufacturers have to undergo so that it may be substituted for its brand reference product at the pharmacy. Interchangeability is regulated under federal law and is a special designation made by the FDA after scientific and technical assessments. These involve additional extensive testing that can take manufacturers have to provide additional investment in time so that the FDA can undergo this really extensive testing to ensure that the interchangeable is 100% exactly the same as the originator product. Most biologics dispensed at the pharmacy are injectable products, such as injectable pens, that are self-administered by patients or by caregivers. When assessing interchangeability, FDA may evaluate potential differences in product characteristics, such as differences in dosing or delivery devices, to help avoid administration errors, misdosing, and other errors that a patient or caregiver might have when administering one of these biologics. It's important to understand that FDA assesses only whether a biosimilar is interchangeable with its brand reference product. And one of the most important kind of keys to this is the FDA does not evaluate whether one biosimilar is interchangeable with any other biosimilar. In other words, FDA does not assess potential differences between one interchangeable biosimilar and another interchangeable biosimilar, even though FDA has determined that both products are interchangeable with the same brand reference product. So you can kind of go and you can look for clinical trials, you can look for data, you can look for research, and you won't find anything because this is not legal within FDA to substitute one interchangeable for another. It's never been done before. So this really potentially harms patients if passed, because a patient will be putting something into their body that has never been evaluated from a scientific standpoint. Pharmacy substitution practices are regulated under state law. The pharmacy substitution laws in all 50 states, including New Hampshire, permit a pharmacist to dispense an interchangeable biosimilar only when the brand reference product has been prescribed and believe the current biosimilar substitution statute, we believe that the current biosimilar statute is working well for patients here in the state and in the other 49 states as well. With all of that in mind, I just wanted to kind of talk about some of the merits why we are in opposition to this bill. We believe that the bill would undermine physician choice and disrupt patient care. The bill ignores the FDA's fundamental role in assessing products for safe pharmacy substitution. The bill would declare interchangeable biosimilars that share reference product as interchangeable with each other, even though the FDA hasn't evaluated whether it would be appropriate for a pharmacy to dispense a substituted product when a physician has prescribed a specific interchangeable biosimilar. Already under existing New Hampshire law, when a physician prescribes a brand reference product, a pharmacy may substitute any biosimilar that FDA has determined is interchangeable with that reference product. So pharmacists already can substitute an available interchangeable biosimilar when a patient has been prescribed a brand reference product.
Can I stop you right there? I'm
Yes, sir.
confused. Has the FDA determined what's biosimilar or not?
Yes. So the FDA goes through testing and they can evaluate and say, yes, this is a biosimilar, which is highly similar.
Right.
But
so-
then there's additional testing for interchangeable designation
Okay.
that a manufacturer needs to additional investment, additional time for the FDA to go through and do extensive testing to receive a special interchangeable designation.
And they have or they have not done that yet.
Yes, that has taken place.
So all we have to do is make sure it's been approved by the FDA is interchangeable biosimilar. That expression that would make you okay with this bill?
No. So, and I'm getting there. But basically, you know, a physician may prescribe a specific interchangeable biosimilar for a reason. They want their patient to receive the actual product. Often, the prescribed products might be under a preferred patient's insurance plan. The physician may prescribe it by name since the product will result in a lower cost for the patient, or the product won't require prior authorization or other administrative hurdles.
So if we require that the doctor has to now, when he writes the prescription, have some kind of code next to it like the generics did,
so they
to
can
say
have
that
this,
it can be interchangeable if it's approved by the FDA.
yes, but one interchangeable for the other interchangeable, it can't happen legally because there's no studies that have been conducted.
When you say legally, no, there's no illegal, right? The FDA is not shutting it down. In your mind, it's not legal, but in terms
But it's
of
also not
the
safe.
physicians all they tell me that they want this bill. Okay, they want it. The Board of Medicine wants it. The insurance companies want it. The only person in this room who doesn't want this bill is you. And I'm trying to understand
Sure, but
the role of the FDA.
the goal of the FDA is to ensure patient safety.
Right. So if the FDA says it's okay,
it doesn't. The FDA says this is not okay.
if the FDA, so okay, the FDA is I haven't heard from them yet. So, but directly, but all right, I'm totally confused, but all right.
And also, you know, physicians have the opportunity to write dispense as written on the prescription, so the pharmacist has no choice to substitute. But this bill, if passed, would make New Hampshire a complete outlier. This is one bill introduced in one state, and this would totally make New Hampshire an outlier. I think this would cause confusion with physicians. So a physician might prescribe an interchangeable biologic to a patient, and all of a sudden this gets changed to another interchangeable if the doctor was not aware of this law. You know, there are different delivery mechanisms as well. So just because one interchangeable is another interchangeable means the delivery might not be exactly the same, and the physician might not know that.
Speaking. No, he's speaking.
Oh, please. My goal was to be brief.
So, as a committee, do we want to maybe just interim study this bill since this is evidently not ready for prime time? Okay. Does anybody have a problem with the interim study? Yeah. I'm asking a question now. Is everybody okay with interim study the bill? Okay. Representative McHugh's first. you want to? He's off. All set. Representative Spear.
In looking at this bill, when it first came out, I did a bit of looking around, and Europe does this extensively. I found all kinds of approvals for this kind of thing all throughout Europe. So this is not really, you know, a pie in the sky, brand new, nobody's ever looked at it before kind of thing. We may be behind the time. I mean, that's typical in some areas. But this isn't really new, and that Europe has been doing it for a while and getting some pretty darn good results. So I think saying that we're taking all these risks and everything has been proven in a very large platform to not quite be the case.
Which is why we should go to interim study now.
Which is fine. So have you been looking at any of that before we say that this is such a high risk?
Well, I'm just going off guidance from FDA, and you know, we obviously patient safety is number one, and you know what FDA says is what we have to go by. Thank you for the question.
But you did take FDA as okay for the PFAS bill.
I said the FDA has screwed that up something fierce.
Thank you, Mr. Chairman. To simplify this, in the previous presentation, the way I understood it is that a drug company comes up with drug A, and then another company comes up with.
These are not drugs. These are biospecific.
Yes, a biomedicine.
I understand.
And a second company comes up with B, and they find out that B is interchangeable with A. Then a third company comes up with C, and currently C is interchangeable with A, but not with B. This law would make A, B, and C all interchangeable, correct?
So it would make B equals C.
Right. So that if B was prescribed, you could use A or C.
Okay.
Well, you'd want to go to C, most likely.
We have the chart.
That's what I just want to clarify.
Okay. Yes. Go ahead.
It's not about the chart.
Okay. All right. Representative Burrows.
Hi, I just have a question. Do you think this is a state legislative issue?
No, I believe this is more of a federal issue.
Okay.
Thank you.
Okay. Any more questions? Are you still okay?
Yeah, just, I mean, I certainly support the idea of studying it because the MDR that Representative Spear brought up were totally different, like Europe's med device regulations and those regulations. So there might be something to be learned from there. My question to Mr. Kent is on the form factor issue. So that's what comes to mind to me. How big of an impact is that when talking about one interchangeable or biosimilar to another? In other words, could I be expecting or have a patient that needs an auto injector that, fires in and then pulls out, right? That type of design, and actually end up with a syringe, like a Victoza kind of pen that you have to dial up and put a needle on. I mean, are the form factors potentially that different?
Getting
That's
a
my
little off
question.
track here.
Well, are the form factors that different? Is that an impact? Is that one issue?
Yeah, I mean, especially if a patient isn't educated on how to use it, if I'm following you correctly.
All right. Good luck
Long
with that.
question, but anyways, I certainly support studying the issue.
Great. All right. So we'd like to make the motion. Representative Burrows, you want to make the motion?
Sure.
Okay.
I mean,
No.
sorry.
Inter- we all do that just to see if everybody's paying attention, right? Okay. All right. Representative Burrows, seconded by Representative McGue, moves interim study. Is there any discussion on the motion of interim study? Oh, McAleer seconded. Sorry. Okay. All those in favor, raise your hand. 1, 2, 3, 4, 5, 6. 6 zip. Okay.
Thank you for your time.
Thank you. Sorry, we can't help you better, but okay. 1571, requiring insurance coverage for glucose monitoring devices for people with diabetes. This sounds like a mandate too. Just killing me. You're killing me. Okay. All right. So how did we left this bill? Was this was a bill? Wasn't this the one that we needed a study, the financial study on the interim we need the mandate study, as we call it. I call it the Murphy Law, but the mandate study.
This one does have a fiscal note. We did complete the fiscal note, but you're correct that it's expanding the scope of the benefit.
Right.
So if you would like to do a mandate study, we could do that. If we would just need the formal request from the committee to the department that you're requesting
Right.
A mandate study. And
Okay.
if you do that, it's good to be as specific as possible as to what exactly you're looking for. If you want us to study this bill as written or with certain amendments or changes or whatever you're looking for. Yes, there should be a fiscal note. No, from what I printed out this morning or last night, there's definitely a fiscal note. We did prepare one, and I believe this is printed from
But
the
what I'm
website.
looking at the back page is this verbiage. Is that what I'm?
There's
Right,
the
and what's the
chart,
next
and then
page?
there's like a page and a half of
Okay.
information.
Okay. So you want to walk us through here and show us what where's it? I don't see any dollars here.
It's indeterminable.
Right. No, we got that. We all have that.
Okay.
But it was zeros.
To be sure.
So,
No, I don't. May I approach?
so it's your fiscal note is indeterminable. Is it where's money? Show me the money.
Yeah. So it's indeterminable. It will increase, but we don't know. We'd have to do a mandate study to give you a rough number. All right.
Okay.
The narrative is there that it goes into more detail
Right,
explaining the caveats.
that's how I remember when we ended up, was that we didn't have any idea what we were talking about.
Yes, so if you want us to do a mandate study for the bill as written, we can do that. We would just need you to formally ask us to do that and specify what exactly you want us to study. Is it the bill as written, or are there variations of it that you would like us to come up with?
All right. But at the end of the day, at the end of the day, we're trying to model it off of the diabetes statute we already have now, which is a $30.
So there's different aspects to this. So the statute we have now limits cost sharing. Limits to cost sharing do not require defrayal. I believe what this bill is trying to do is mandate coverage over these glucose monitoring devices for type 1 and type 2 and gestational diabetes. And I think it's my understanding, and my expert left because he said you weren't going to take this up. My understanding is these devices are already covered routinely for type 1 diabetes.
Type
Their,
1.
their utility for type 2 and gestational diabetes, I think, is a little bit more gray. So those would not typically be covered for treatment of those conditions. So what we could do if we were going to do a mandate study is look at what the clinical criteria are for using these devices based on the medical science as it is now, whether it would be appropriate to do that or not. And then if there is a utilization for this, we could also look at estimates about what this would cost to provide these devices to this expanded population.
Do we know how much these things cost?
It depends on the device, and unless it's in the fiscal, I do not know off the top of my head. But there's different costs associated with it too. It's the device itself, and then there's different parts of the device
The strips.
that have to get
Strips and
not necessarily. I think these are the implantable
oh,
ones.
these are the implant. Oh,
So there's
these are the ones
different
you have to.
parts, and again, I'm not an expert on this
These are
device.
the ones you have your phone. You can.
Yeah, but there's
talks
different
to
things that you
Bluetooth
have
your
to
phone.
replace in them, and I think
Right.
depending on the device, there's different costs associated with the different things that need to be replaced. And I think some of them you have to replace certain things like every 2 weeks. Some of them are, and I don't know the details of that. That we would need a mandate study to do a survey of what devices are available, the costs associated with them, and then the costs associated with expanding it to this population that under current
Right. But
policies
you're saying
is
type
typically
1
not
is covered now.
Yes.
Okay. Because that's the one that's most critical, I think. But you guys, what do you guys think about
I think a mandate study.
mandate study? Okay. Great.
So you'd have to vote on that?
Yes,
or
we do.
send
No,
us
I've
something?
done that.
Yeah.
I know I have to send a
So
letter to
there'd
Alex.
be an official thing. And
official
I
letter
would
and
just say-
saying, but we'll have in it the parameters that we want to do.
Yes.
So, yeah. So if you could give me a rough draft, what you think is probably the right questions to ask,
I will work on that.
you could do that for me. That'd be
Yes.
great. Send that to me, and then we'll take this up again some other time.
Okay.
Once we have that. Okay.
Sounds good.
All right. So once we have a letter, once we have what we're going to be asking, what we're thinking about, then we can take action on this bill. That makes sense? Okay. It's noon. It's time to go because I got to go. So, should I, the Democrats decided to give me a Valentine present.
Says cutie pie on it.
Thank you. No sharing here. The lady Democrats. I would be very surprised if you would give me a Valentine present.
It has THC.
Oh, it has THC in it, right? Okay. Sorry about the delay, but we now have the final amendment from Representative Leon. And so I'm going to start right in with we'll take a motion from Representative Burrows, who will move ought to pass on the amendment.
I would like to.
Seconded by,
Oh,
We don't know what's in here. Okay.
we're just passing the amendment, because then I was going to ask Representative Leon to tell us what's changed. But I thought we start with a motion.
okay. I'd like to move OTP on the amendment 0680H.
Okay. We have Representative Petusek will
Wait, did I get the
second.
number
No,
right?
no, no, you're right.
Okay. Okay.
0680. Okay. Multiple seconds. Okay, Representative Leon, why don't you tell us what we're looking at?
Thank you, Mr. Chairman and members of the committee. This is almost exactly the same as what was done yesterday in the subcommittee, except for two changes. On page 1, lines 25 and 27, it now reads that many years of work have led to this effort, which addresses the following goals to put the state of New Hampshire in the driver's seat to focus on harm reduction, not profits. And it had cited a memo from the governor previously, and that was an oversight on my mind. I really shouldn't be naming anybody within the purpose and intent. So I removed that. So I figured that that was probably a very good cleanup there. The other is when I was shifting on page 33, lines 5 through 11 replace the previous lines, I think 6 through 17. So as I was shifting the money away from pensions, because I was trying to match this to what had passed Ways and Means before, and the stated preference of many not to have any money go to pension funds, all the other versions that I saw sent at least 15%. So I had retained that, which really was an oversight. The idea of not entangling any other federal agencies into cannabis within New Hampshire is a good argument to not have the pensions receiving any money. And there's a lot of reticence from people to have their pension funds paid by cannabis funds. So that 15% that had previously been going to the pension funds is now added to the education trust funds. I know our schools need it and our kids need it, so hopefully that change is acceptable. Otherwise, everything else is exactly the same as was presented to the subcommittee yesterday.
Great, thank you. Do we have any questions from the committee members? Yes.
The education trust fund, I sort of have a problem with that because of the voucher program. How can we ensure that this is going to go to public schools and not just to the voucher program? Is this out of line or?
So all it does is it goes to the adequate education grant that is available to every student that enrolls in a public school, and now it's to those children who are seeking education elsewhere. That I think is one of these more policy decisions that we have. Where else do we send it? Do we send it to the general fund for it to go somewhere else? With it offsetting SWEPT, I think we can have those ongoing discussions about whether students who aren't in a public school should be means tested, whether students in public schools itself should be means tested so that we're not paying for millionaires to go to the public schools. But I think that's sort of outside of the scope of this. Given that we're going to have to be spending a lot more money on education going forward, it seems a prudent place. I'd be happy to amend it to the general fund if you prefer that, but to me, it seems the best choice.
Yeah, I would say that a constituent of mine this morning, after commenting about our being on MUR last night, also mentioned that as long as that money goes to reduce taxes, then it's a good thing. And clearly putting it in the trust fund will help be directed back to our property taxes.
Yes, and with that, there is the note that it specifically reduces the swept so that that will go directly to property taxpayers with all of that money directly to their tax bills.
Okay. Any other discussion on the motion about to pass on the amendment?
Those are the only two changes.
Those are the only two changes. Seeing none, the clerk will call the roll.
Mrs. Ought to pass as amended. And
You might want to turn your mic on.
yep. Thank you. Representative Ammon,
Yes.
Grassi,
Yes.
Petusik,
Yes.
Post. Nope.
Yes.
Yes. Tudor,
Yes.
Bocelli,
No.
Thaxton,
Yes.
Walsh,
No.
Burrows,
Yes.
Herbert,
Yes.
Clark, yes. McAleer,
Yes.
Representative Bolden,
Yes.
Representative Calabro,
Yes.
and Filio is, who's Filio's place? McGee.
On the amendment, yes.
Okay. Yep. Representative Gibbs,
Yes.
Spear,
Yes.
Sullivan, and Chairman Hunt.
Yes. So, who do we?
Oh,
Okay, so
Terry, who's?
Terry is.
Oh, I didn't even
Osborne.
see him there.
How
Oh, my
could you miss it?
goodness. I don't know. He snuck in. Representative Osborne.
Yes.
Okay. Great. So 18-2?
18-2. The motion now is ought to pass as amended. Is there any discussion on the motion? Seeing none, the clerk will call the roll.
Oh, yeah.
Okay. Oh, excuse me. Representative Burrows, second by Representative Petusek.
Do I need to do it or?
No.
Do I need to say it?
No, I already did it.
You mean you speak for me?
I can.
All right. Right. This
'Cause
is,
I'm-
ought to pass as amended. Representative Ammon,
Yes.
Representative Osborne,
Yes.
Petusik,
Yes.
wait a minute. Oh, McGee.
No.
Well, no, I have Osborne twice,
Osborne should be Terry.
right?
Happy to vote twice.
Oh, Osborne was on the sheet?
Yes,
Where did you find that sheet?
she gave it to me.
Okay.
All right, so McGee is this. Hang on. Where is it?
A no.
So that's a no. All right, so that, I'll change that, McHugh. All right. Representative Post,
Yes.
Tudor,
Yes.
Pacelli,
No.
Thaxton,
Yes.
Walsh,
No.
Burrows. Yes. Herbert,
Yes.
Clerk, yes. McAleer,
Yes.
Bolden,
Yes.
Calabro,
Yes.
Grassi,
Yes.
Gibbs,
Yes.
Spear,
Yes.
Sullivan, and Chairman Hunt.
Yes. Yes.
All right.
Okay.
17 to
17-3. And would I assume there would be a minority report? Okay, Representative Walz? Okay, so the motion passes, vote 17-3, and we will leave it on the regular calendar. All right, we all set?
Wow.
The executive session is ended.
That was.
What do you think? That kind of charm? Kind of charm?
It's Groundhog Day.